Welcome to episode 51 of the Lebanese Physicians Podcast. And today we'll be discussing gaps and innovations in mental health care in Lebanon and the MENA region. And our guests today are Dr. Sara Catherine Mourani, who's currently a psychiatry resident in Miami, and Dr. MohammadAli Jardali will be introducing her soon. And we have Dr. MohammadAli Jardali, who's back for more. He's been out for a while, family medicine graduate from the American University of Beirut, and then recently moved to Saudi Arabia and has been out of commission for a while, but now he's back, back in action. Welcome back, MohammadAli Jardali.
It's good to be back.
And if you can introduce Sara, that'd be great.
Definitely. I met Kara actually back at AUB, and now she's currently a first-year resident at the University of Miami Miller School of Medicine Psychiatry Program. She's the founder of Ta'bir, a tech startup, an application that combines artificial intelligence and one of her research interests, actually, and she combines it with psychiatry, and it's specifically aimed at tackling mental health in the Arab world. She's also interested in systemic change in mental health, and she has multiple publications, which we'll probably have the plugins later, tackling the necessary policy reforms to mental health systems in Lebanon specifically. She is also involved in community psychiatry initiatives such as Lebanese online mental health support group, and she is excited to work on many more projects during her residency. So I think we're going to have a very rich discussion with Kara.
Yeah. Welcome to both of you. And Sarah, it's great to have you on the podcast. So as we're discussing more innovations in mental health care, can we discuss a bit the traditional mental health care model in Lebanon and the MENA region currently?
Sure. So I can talk about it. Oh, well, before I get into that, I want to say thank you so much for having me, of course. It's an honor to be here. And yeah, I'm expecting some very rich discussion also based off of like some of the I listened to some of, the previous episodes. And I'm very excited for what it is that we're going to be able to produce out of all of this. So thanks again. And so basically, first of all, I'll kind of talk about what the classic and traditional model is for psychiatry, which is kind of also what's practiced in the Middle East, which is basically what's called the chemical theory of psychiatry, which I'm sure you've all heard about, which is basically that psychosis is because dopamine is in excess, or mania is because of this, or depression is because of a depletion of serotonin. So this is kind of a very traditional, and if you like, retro, and in my opinion, a bit reductionist view of what is at the root of mental health. And then based off of that theory of how we conceive of the mind, you have medications which are tailored to this, which is basically to fix mental health disorders. You have to increase your serotonin, you have to decrease the dopamine, et cetera. That's kind of the classic model. And this is, what we practice throughout the Middle East. A lot of, sometimes treatment modalities can get very, very pharmacology heavy. And then more specific to the Middle East is that, we learn about something called the diathesis model early on, which is basically where, sure, there might be pharmacological, maybe chemical factors, but also there's sociological and psychosocial and etc. factors. So in the Middle East already, I see that there's maybe a lot more of a focus on this, the chemical and biological factors versus maybe looking at a bit of a broader picture, looking at, for example, cultural factors, genders, sexual orientation, etc., which are all factors that play in a person's mental health. And another thing which is maybe specific to Lebanon, although now the current events are kind of deconstructing that, is that a lot of people kind of forget, maybe because there's been this national amnesia of what's happened in Lebanon, we forget how much trauma has been carried over from the civil war, from generations of, in fact, of civil strife and political unrest. And we forget how these things can impact us, even though we have kind of normalized them. I'm talking pre-explosion, pre everything, because that's kind of, now with the explosion and the pandemic, we've kind of begun to finally remove the tablecloth and kind of see the rot that's in the woodwork of the table, so to speak. So that's finally unfolding. But definitely before that, it does seem like we kind of forget how stressful life is in Lebanon and what we've been through and what the older generations have been through. So that's kind of what I've seen. And then with regards to the chemical framework, now, even in the West, people are moving more towards less less like focusing on, okay, it's the chemicals that are imbalanced, and maybe looking more at, like, for example, how the microbiome, in fact, of a human being might be interacting with brain chemistry to be able to cause inflammation. And neuroinflammation seems to be also very much implied in neuropathology. And then what's really exciting and what I'm really interested in, if you'd like me to speak more about that, if you'd like me to take the direction of the conversation more towards that, is something called neural computation. So have you guys ever heard about that? Or, you know, like, also, what are you guys thinking about some of the things that I said?
Yeah, definitely. So I think this was a like overview and a big picture of the different modes approaching psychiatry. And I guess our experience in Lebanon, like we all know, like it's the nation on Xanax. Like everyone and their mother is on every sort of anxiolytic. Every house has someone with depression. And we really, like you said, a one-dimensional approach with psychiatry. It's very based on pharmacopsychiatry. It's very big on medication. Just take a pill and you better. And there hasn't been a lot of effort in terms of psychotherapy and different modalities of maybe addressing the root causes of all the psychiatric illnesses. We talk a lot about the biopsychosocial model, but we focus a lot on the bio and kind of reduce the psycho and social impact. So I guess a good way to move the conversation forward is talk about maybe about the role of AI and innovation. But maybe before we go to that, maybe we want to address a little bit like the gaps, current structure in terms of like systemic barriers for people reaching those types of psychotherapy.
Sure. So if we're talking specifically in Lebanon, the gaps are aplenty, as you can imagine. So one of the gaps that we can already think of is that there's a huge shortage of both mental health and psychiatrists, like mental health professionals as well as psychiatrists. You only have about 1.5 psychiatrists for 100,000 people in Lebanon. So already that's a major issue. And the problem is that in Lebanon, because we faced collective trauma, a lot of mental health practitioners also now suffer from mental health problems, who then need mental health practitioners, but there's a shortage. So it's this kind of vicious cycle of shortage, which, you know, is kind of repeating itself. So definitely that's one of the gaps that we see. Another gap is, you know, something that's been present before the events of 2020 have unfolded, which is that mental health is still very taboo. You know, we have an attitude of no shit halak, basically, which is, you know, you just have to stop feeling the stuff and you'll be fine. Just repress. It is kind of like a popular coping mechanism of choice in the country, unfortunately. And so that's definitely something that will prevent someone from seeking care, because, you know, they're embarrassed, or it threatens their identity as someone who's supposed to be strong, or, you know, it could sully the reputation of the family, for example, if there were to be someone who seeks mental health. So that's another issue. Another issue as well, and this is a study actually that was done by IDRAK, the mental health NGO, actually showed that one of the main factors that actually stops people from seeking mental health isn't taboo, although it is an important issue, but it is actually lack of awareness about the resources. Because when you think about it, a lot of the resources that we have in mental health are centralized in Beirut, first of all. Like, you don't have a lot of stuff near the borders, like in Akkad, or, you know, in other areas, basically, especially near the Israeli and Syrian borders, where there's a huge shortage of any kind of, you know, health worker, or any kind of provider of aid in general. There's that. And then another problem is that a lot of the way that we talk about mental health is in English. We don't have as much of a developed maybe language for mental health in Arabic. So that's one issue which makes it less accessible maybe to people who don't speak English. And then another problem is that a lot of these kinds of resources are also advertised on social media, and like stuff like Instagram or Twitter, which is again kind of targeting maybe a specific type of generation. and a specific type of population. Whereas some of the more effective campaigns to be able to reach a broader audience would be national TV. But the last time campaigns were done on national TV was actually before the pandemic started, for some reason. So that's another gap there. And
then reimbursement is a big deal, right? A lot of third-party payer insurance don't cover psychiatric illnesses. The MON and SSF doesn't cover psychiatric or admissions.
Right.
And actually, I remember once I did a podcast with Drs. Malouf and Ghandour on their study that was published after the August 4th explosion. And one of the things that came up was what you just discussed, Muhammad Ali, is that people with low resources did not seek actually mental health care, and part of it could have been related also to lack of awareness, but also to lack of funding to be able to afford the mental health care services for their kids.
Right. And that brings up another topic, which is that the mental health branch of the public health of the Ministry of Health is not technically officiated, and actually there was a draft law which was created to reform the only law that we have, in fact, which is pertaining to mental health. And part of that draft, which was endorsed by the mental health branch, was supposed to make it a legitimate branch so that it could get more funding, so that then the state could fund more hospital stays, more outpatient services. But till now, this draft hasn't been officiated. It's basically kind of lying in a drawer somewhere. So that's another very important issue, especially in light of the economic crisis.
Yeah, and I always say, like, follow the money. And once you figure out that psychic illnesses is not even recognized as a legitimate illness, like in with private and public insurance schemes, it makes sense that we don't have any inpatient capacity, and the outpatient capacity is limited. And a lot of patients, when they want to seek either a psychiatrist or a psychologist, the waiting times are really very long compared to other services. And people in Lebanon aren't used to wait months and months to get an appointment. They usually expect a quick appointment, and unfortunately, with the very few psychiatrists and the very few psychotherapists that we have, the waiting lists are very long, unfortunately.
Right. Yeah. And it's unfortunate that even the resources that could accommodate people who don't have the financial means to be able to seek them out, even those are, again, like, not very advertised. So it's just kind of limitations on every direction, really, on every front.
And this is, I think, a segue into, I mean, traditionally, right, before it's just discussing mental health services were localized to Beirut, people would have to come in person to see somebody in clinic. But I think the pandemic may have changed things somewhat. So have there been any advances or innovations in online and digital mental health services in Lebanon? And what are the future plans for that? I know, Sara, you've been involved in some of these projects. So if we can discuss a bit some of the innovations that have already happened and some of the future projects on the horizon.
Sure. So, okay, so I did a small initiative. I wouldn't call it innovation. It was just me, like, in a pandemic, and I was, like, lonely and sad and just studying for finals. This is basically what Fashet Khalid was, which is what I wanted to do. And so that's why I thought, okay, everything's gotten on Zoom, and people are, frustrated, and not just because of the pandemic and because of the loneliness, but because of the more pressing issue was the financial crisis. This was post-revolution, and so and on top of everything, no one could even talk about it because of this further isolation. And so I thought, why don't we use this new thing that's become popular, the Zoom, and just create these little chat rooms, these support groups, basically, not group therapy, but like places where you have a moderator, kind of like, in Alcoholics Anonymous, where you have a member of the community and you're all together, and there's specific goals, like there's the Yalom's 11 goals of a support group, which is basically you create hope building techniques, you share resources, and then ultimately you have to create catharsis together. So I worked with a psychotherapist on this, and together we started moderating these chat rooms where basically we would just kind of like advertise the initiative everywhere, and then anyone could basically register. And then we would just sit and talk, and together we would kind of, try to tackle these 11 objectives, which is that everyone talks, everyone vents their frustrations, we exchange resources, we help each other out. And then ultimately we reach this catharsis that we weren't able to achieve because of, the separation. So I wouldn't call it innovation again, because again, I was just like in my room, like on Zoom with, Dr. Majlalani, who was helping me out. But definitely it is a good segue, because it is kind of like it is kind of, a very proto telehealth kind of experience, which is, what you're basically alluding to. So telehealth specifically, the actual innovative thing. So telehealth has become more popular in Lebanon. You do have several companies which have adopted the model of basically having therapists which have reasonable fares. And one of the companies, for example, is Mindsum. And what they do is that they'll have a roster of basically psychotherapists that you can register with. You can take an appointment, and you have unlimited texting with this therapist. I think you buy weekly packages or something like that. And then you talk with this therapist, and you talk with them online, and that's one of the models that it seems like has become popular, not just in Lebanon but also in the rest of the Middle East. You have firms in Dubai, you have firms in Saudi Arabia doing this. I think the name of the Saudi Arabian firm is Labay, if I'm not mistaken, or something like that.
Not sure.
Yeah, and then there's Shazlong, which is in Dubai.
Yeah, Shazlong's really big.
Yes, Shazlong is getting very popular. So it has become a popular model in the Middle East, and why shouldn't it be? I mean, it's so convenient. People might feel like, it's respecting their privacy a bit more, because then they don't have to be in a waiting room, and then, maybe potentially meet up with someone that they know, which is the kind of like the ultimate fear in our culture. And yeah, so definitely has become a lot more popular in Lebanon. And then in the States, they've even started producing like telehealth firms for psychiatrists, where they just kind of, have like a bunch of people in their employment, and they just see patients remotely. So yeah, it's become huge.
And are there?
Yeah, and I guess.
Go ahead. Actually, just kind of one simple question: are there any clinical trials showing the efficacy of telehealth services compared to traditional health services in psychiatric care?
So I can tell you just about one specific study I know of, which had to do with psychosis and schizophrenia. So because funnily enough, well, not funnily enough, but interestingly enough, the rates of schizophrenia have increased during the pandemic for several reasons. And what they showed was that telehealth was an adequate method to be able to deliver care to schizophrenic patients during the pandemic, like to a similar degree as face-to-face appointments. So yes, it can be very efficacious, and it's when you think about it, it's convenient. You feel more anonymous, and you feel more comfortable, maybe because you're in your own environment. There might be that limit of maybe you're not adequately reading the body language of the other person that's with you, but so far the benefits have seemed pretty good. Yeah, and sorry, MohammadAli, I think you had a question.
No, I was just like saying, the cool thing about like all those telehealth initiatives, including Fashat Khila, it's honestly like a way to democratize seeking therapy, right? We were talking about how the current structures have barriers, and how sometimes those structures are exclusionary. So maybe one way to bridge the gap in terms of access and affordability is through going online. Of course, that brings up a whole set of other problems in terms of bridging the digital divide, but it does solve one problem in terms of affordability and accessibility, right?
Absolutely. And then you could make the argument that, like, a lot of people have smartphones, and you can kind of just log into the thing, or especially because if you make an effort, especially to advertise on platforms that everyone has access to, then again, you're also like kind of trying your best at least to reduce these divides as much as possible. but definitely, yeah, there you'll have age limitations. You will have like socioeconomic class limitations. But you're right. It is a good way to bridge. Absolutely.
Yeah, and I guess we tend to think of like, at least in our discussion, like I want to make sure like we're not uh, reducing the population and giving it one-dimensional. The population is obviously diverse. You have different needs, and you have different groups that are not homogenous at all, and that have different needs and different gaps that need addressed. So I don't know if this is like a good point to talk about your involvement with other innovations, and if you want to talk a little bit more Ta'bir, maybe.
Sure. So the blurb version of Tabir, just because it's still under development, is basically me and a colleague of mine. We're good friends because both of us have interests in artificial intelligence. We found out that there was this competition at AUB, which was this entrepreneurship competition for engineering. And one of the categories was artificial intelligence. So we kind of bumped heads, and we decided to incorporate both of our research interests, which for me was psychiatry with AI, and his was AI and software development. And we created basically a program that's still under development, whereby we could use artificial intelligence by training models through different modalities, be they video, be they speech, etc., to be able to make predictions, to be able to even maybe deliver certain some element of support to people, and all of it in Arabic, because the vast majority of the resources are in English. And so one of these things, like you were saying, one of the ideas behind this was to be able to bridge this gap, because you can download the application from your smartphone, and you could basically have an avenue to be able to vent wherever you're at. And the nice thing is that a lot of NGOs actually will provide interventions, applications, and stuff like that for free to vulnerable groups that basically, like for example, refugees, etc. And so there are a lot of avenues to be able to give access to this kind of application to people who are otherwise don't have necessarily the means. But even without the help of these NGOs, the application is pretty accessible financially to everyone. And so that's kind of Tabir in a nutshell. Again, a work in progress, but yeah. And so we ended up winning the competition, and now we're working on it, and we're really excited. And another maybe unfun fact about artificial intelligence applications in the MENA region is that I think literally all applications using artificial intelligence to deliver care to people in the global south are all created by the Western world. So I think it's also important to mention that in this digital age, it's important to have digital agency. The artificial intelligence applications that you use to deliver care should be created by the communities, in my opinion, that you are trying to heal, because it can't always just be one person delivering resources to the other. There's a lot of, I think it can get quite problematic. And so that's another thing that we wanted to tackle, and that we hope is going to be a trend in the future.
And I agree. I think, there's cultural differences among different countries. Countries are very far apart, and there's a lot of cultural differences. So if you develop an application by somebody in the Western world that does not necessarily mesh with the population in a country that's 7,000 miles away.
Mm-hmm. Absolutely.
No, I think what you're saying is very important, and we're just talking about like how the society in Lebanon and the Middle East and North Africa is not homogeneous. Like, it's very heterogeneous. There's a lot of diversity, and only someone who grew up in this culture can understand the nuances, can have an app that or a platform or modality, whatever you want to call it, to understand those nuances and to address diversity. So no, I want to salute you and congratulate you on all your efforts, and wish you the best with the Ta'bir. And I know you're going to do great things.
Thank
So
you.
are there other similar apps in the Western world that have been successful?
In the Western world, yes. However, they tend to use one modality. So it'll either be like, for example, only text or, well, yeah, but basically most of these kinds of applications are only text. In academic context, they might be a bit different, but if we're talking like both commercial and academic, which is the directions that we're taking, then not all of them, no, there doesn't exist something that is a multimodal, basically, learning model. And then in Arabic, definitely it doesn't exist. So that's something that we really wanted to tackle.
And I think, I don't know if you want to comment maybe about some controversies with a lot of those telehealth and new modalities. If you want to talk maybe about cerebral, I know there was a big controversy with them a few months ago, how they were pushing ADHD medications, for example, and how they were being pressured by patient satisfaction, right? So patients were going onto those apps expecting to get their medication prescription, and sometimes it wasn't indicated. So there was a big controversy, and a lot of people working for cerebral like recently came out and spoke against the practices.
Yeah, definitely. I mean, you raise a really, really important and interesting point. I've been seeing this a lot more now that I'm in the States, which is that mental health has become a lot more consumerist. Like it's insane the amount of advertisements you're getting now for like Prozac or whatever, and the way they're pushing it as kind of like this new product, and your mental health is now a new product that you need to spend money on so that we can profit off of it. Like it's become like, I think it's almost kind of like one of the disadvantages of mental health becoming such a hip thing, which is that now maybe it can be used for profit in the wrong way. And definitely that's something that I've witnessed here. And with regards to other controversial points regarding new modalities in general, one of the problems with artificial intelligence anywhere, but also in mental health, is that it really is very much shaped by the programmer. And so if the programmer has a very biased and very, narrow outlook, and especially if the programmers are from a very homogeneous class, then you're not necessarily going to collect the appropriate amount of data sets to be able to program your model. And so your model might not be effective for communities that are more vulnerable and that are minorities. And that also applies to, for example, detection in academia, when you're talking about detection of autism, for example, or other kinds of disorders. Using artificial intelligence, there exists a huge gap in diagnosing women and people of color for all of these different things, because the models don't necessarily incorporate a varied amount of data sets. And that's another problem with using these modalities. So that's another controversy. And that's why you have to be very careful of who you hire as your programmer. And you as a programmer, you have to be aware of the ethical implications of what it is that you're doing. So that's definitely another problem that arises with these new innovations that people have to keep track of.
There's, a lot of communities, right, with no access to internet services. One, they don't know how to use them. And number two, now with the internet getting so expensive, there's a lot of communities that will not have access to either smartphones or internet services. So how would you reach these communities? Would you send representatives there to be around with the people and help them connect, or are they not able to connect?
Well, that depends, because some services, like if we're talking about, me specifically, or we're talking about in general, like telehealth, etc.
In general, mental health services in general, online mental health services.
Yeah, so for online, definitely it's going to be a problem. Everywhere electricity has become a problem. Everywhere it's become very expensive. So yeah, definitely I see it as being a limitation. There's only so much that like an NGO could, like NGOs in these respective, like districts that they operate in, that they can do. I think to some extent, we have to be aware of, like, there's a spectrum, I think, between like mental health and psychiatry, and then on the other hand, and like structural factors. And structural factors basically meaning the economic and political factors that are kind of impacting our situation and our mental health to be the way that it is. And it's an unfortunate reality that for some of the resources, such as like telehealth, etc. Really, you have to tackle the structural factors, before you can tackle the mental health. There's a hierarchy of needs, kind of what needs to be tackled, unfortunately. So for them, what the priority would have to be to at least psychologically stabilize them while you're working on these structural factors, so that you can give them aid and not just kind of focus on fixing the country, because that's going to take a very long time, right? It's going to have to be live initiatives. It's going to have to be dispatching more people to those remote areas, unfortunately, especially if we're talking, again, more towards the borders of the country. It's the sad reality, unfortunately.
Yeah, and what you're saying makes so much sense, right? I mean, faced with the cumulative and compounding crises of Lebanon, I guess it is normal to be depressed, and it is normal to have anxiety, right? It's a normal reaction to an abnormal situation, right? If you're walking in Lebanon right now and saying "La vie en rose" and you're not worried about anything, I would be worried about your coping mechanisms, right? You're
Absolutely.
either in denial.
Absolutely, yeah. And if anything, maybe us forcing ourselves to see la vie en rose for so long is the problem, is that we were repressing so much and not dealing with so much. And it's not saying that it's acceptable for the mental health situation to be the way that it is, and we need to stabilize it as much as possible. But yeah, things are pretty crap.
Yeah, but you raised a point earlier, and I want us to back to it in terms of the data set, because I think that's really important. And we know if you put bullshit in, you get bullshit out, right? So
yeah,
that's the number one mantra right now, and AI is the data set. It's only important to have a local programmer and someone who understands the culture. But where do you get your data set, and how do you make sure it's diverse? Because if what you have is very one-dimensional, and if you have a racist data set, right, then you build in racism and all those problems into your AI product. So I guess how are your strategy about getting a well-represented and well-rounded data set in Lebanon and the Middle East?
So if we're talking in Lebanon and the Middle East, it would be the same kinds of models that we use for recruiting people for research in general. You have to, again, because it's important to know your communities, you have to know your communities. You have to know what kinds of communities it is that you want to be represented. You have to focus, if anything, not just be aware of, but focus on the vulnerable communities, because those are the ones that will be more difficult to have awareness to put in, and it's easier to leave them out because people tend to focus on the mainstream. And for example, if we're thinking Lebanon, we're thinking you have to think about domestic workers. You have to think about for them, maybe you can't deliver things in Arabic, but if we're talking about mental health in general, or research about mental health in general, you have to keep in mind these communities. You have to think about refugees. You have to think about people from all sorts of different religious sects. You have to think about people who are not just refugees in general as a bundle, but maybe people who have been double displaced. So that's the thing. You have to know your community, and based off of that, you have to know who it is that is most likely to be left behind, and then add them into your data set.
I think it's been a good podcast discussing the potential innovations in Lebanon and the Middle East. But what are your thoughts about the future of AI and telehealth, mental telehealth in Lebanon and the region? I know when we discuss Lebanon and the region, I mean, all of us can see that I think there's a huge gap between the different countries in the region. I think some countries are getting to be a lot ahead of other countries. But how do you see the future, specifically in Lebanon and potentially in other countries in the region?
So what I see, first of all, in general, and then I'll focus a bit more into the specifics of Lebanon. What I see in general, what I'm very interested in, and I think breaks away very nicely from the traditional chemical theory of psychiatry, is basically what's called neural computation. And what neural computation is basically that you take the neuron and you see how it encodes information. And then the information that the neuron encodes, you basically create mathematical and statistical models to model certain cognitive processes. So basically, you're taking your hardware, which is the neuron, and seeing what kind of software it produces based off of mathematical modeling. So how does this neuron make this kind of subjective experience, right? Now, we've been able to do this at a very basic level, like, okay, when neurons do this, and basically they create this kind of neural pattern, it's this kind of software, which is the experience of pain. And so what I'm hoping to do, and what I'm hoping psychiatry will do, is that we can develop this further and make models for more complex cognitive function till we know basically how to mathematically model out conscious experience. And based off of that, you can then start modeling deviations from the norm, quote unquote. So then you can start figuring out schizophrenia, like what kind of deviances in mathematical modeling happen there? What's the difference in the software for mania? What's the difference in software for all of these different things? And I think that we don't have a physiological model for how the brain works. We have one for the kidney, we have one for all of those things. And based off of that, we can make we can see how deviations of those things can produce pathology. We need a physiological model, in my opinion, of the brain. And I think neural computation is the answer to that. It's figuring out how the software that is consciousness is produced. And so I'm hoping to see that everywhere. If we could do that in Lebanon, I mean, we have a lot of bright minds. If we could produce some kind of a multidisciplinary approach to researching this, especially that, we have a lot of diversity in Lebanon, a lot of cultural diversity. And I think it takes diversity to be able to take on such a project. I mean, that would be something that would be the dream, really. So that's kind of my vision of psychiatry.
That's beautiful, and it's a really exciting time to be working in psychiatry. Like I said, there's so much innovation going on, whether through the brain-gut interface and the microbiota, and whether through artificial intelligence and neural computation. Just so much innovation going on. The brain is really a mysterious organ, and I think now's the time to explore all of that. And hopefully, a lot of patients will benefit from all the innovation going on. There's a lot of effort, like you said, into commercializing the products, which can be a good thing and a bad thing. But I think there's a big need, and with people like you at the forefront of innovation and bringing all this new technology to patients in need in real time, live, and learning as you go, right? That's the only way to do it. I really congratulate you on all your efforts, and can't wait to see what the future holds.
Thank you very much. That was very kind. Thank you. And I hope, I hope to see these dreams come true. In Lebanon especially, I hope.
Inshallah.
Yeah, thank you. Thanks to both of you for being on the podcast. And Sara, we will be following your progress on the app and updating everyone on where we get with this. But that's great work.
Thank you. And thank you both so much for having me. And I had a wonderful time and a very interesting conversation indeed.
Yeah, and we should say that Sarah just finished a night shift. So I'm really impressed that she's that coherent and able to form full sentences and did not crash halfway through. So
it's the high of sleep deprivation. But thank you. Really, thank you.
Thanks.
Our pleasure.
All right then.